Welcome to the MamasteFit podcast. In this episode, we're going to be talking all about labor stalls specific to what should you do if your baby is having a hard time navigating through your pelvis. So it could be related to your baby's position and how they are moving through the pelvis, or it could be related to their path or their actual structure that they're trying to navigate through. We're going to discuss what is a labor stall and how you can know that you're having a labor stall related to those two issues, plus some ways that you can resolve it. Welcome to the MamasteFit podcast. This is Gina, perinatal fitness trainer and birth doula.
And I'm Roxanne, labor and delivery nurse and student midwife.
And this is the MamasteFit podcast, where we empower you on your prenatal fitness, birth, and postpartum return to fitness journey.
Our podcast shares how to move throughout your pregnancy to stay strong and comfortable, because pain is not a requirement of pregnancy. Understand the science of birth and how to approach recovery after birth.
We share our personal experience as mothers navigating this stage in our lives, plus our professional expertise as birth workers and fitness professionals.
Our goal is to help you feel confident as you navigate the perinatal timeframe for an empowering pregnancy, positive birth, and postpartum journey.
We're glad to have you with us on this journey and that you have chosen us to support you.
Welcome to the MamasteFit podcast. In this episode, we're going to be talking all about labor stalls related to your baby and your pelvis and the path that your baby is kind of navigating through. And it's important to note that with the pelvis, it's not just bony structure. There's also muscles and ligaments and organs that your baby is navigating through. And so we're going to break down, one, what is a labor stall? Two, how do you know that you're having a labor stall related to those things, and some ways that we can resolve it. So first, Roxanne, what is a labor stall?
So a labor stall is when your labor either stops progressing or it slows down. So either your contractions stay the same, but your dilation, effacement, or station of your baby is not changing, as well as your temperament is not changing. Or your contractions now are starting to space out. So maybe they were 2 to 3 minutes and now they're like 5 to 6 minutes apart, not as strong. And then again, the dilation in your temperament has not changed as well. Because the three different things we're looking for with labor progress is how is your temperament changing throughout your labor? What is your contractions doing? Are they getting closer together, more intense? And then obviously, what is your cervix doing? But I think the temperament and the contractions are usually more of a better indicator of how your labor is progressing.
It's important to note that labor is not this linear path either. It can ebb and flow, increase in intensity, kind of decrease in intensity based on your individual needs. And so it's not once contractions begins, it just linearly increases in intensity until your baby's born. There can be some flowing with it as you navigate through phases, as you shift from place to place. So like when you go from home to your birth location, it can vary depending on who's in your space, how you're feeling. And so again, it's not just a straight line of progress. There could be some wiggle room here and there as you go. But the main things to look for is your temperament starting to shift? Is your contractions getting closer together? Are they increasing in intensity? And then is there some change happening to your cervix? I agree where I find that your contraction intensity and your temperament are probably my best guesses on how things are going. You don't always need to know what is going on with somebody's cervix to assess their labor progress, mostly because your cervix is not a crystal ball. It doesn't predict really anything. It's not going to tell me that your baby's going to be born in 35 minutes. It's not going to tell me if your baby's going to be born in 8 hours. It's just really a moment in time. And things can really shift very quickly with cervical change or very slowly with cervical change, and it doesn't necessarily equate to an issue. So paying attention to your temperament, is it changing? Are you going from being a little bit more present within your environment to kind of in your own little world? Maybe things feel a little bit more chaotic and confusing for you, and then all of a sudden you feel a strong urge to push. So that's a pretty clear progression that labor is going along the lines that it wants. And then your contraction intensity, do they feel more intense than before? Does the sensation feel different than before? Are they closer together? Are they lasting a little bit longer? So these are all external signs that we can look at to determine that labor is progressing well. And I also find that inside, that things are going good. You're things are progressing. It might be slower than I would like. I would have liked to already be done with this. But inside you could probably feel things are normal, things are progressing well, or something's off, something's going on. So the first type of labor stall that you can have is related to your baby's position. So if your baby is not well aligned to the pelvic level that they are trying to navigate through, they're going to have a little bit harder time fitting. And so your body's going to be working really hard to help them rotate so that they align better. And so I like to use the analogy of your baby is a square peg and your pelvis is a square hole. And so they're meant to fit with one another. But if you slightly aligned the square to be more like a diamond and you try to ram it into your square hole, it's not going to quite fit. But once we can rotate and turn it, then it just slides right in super easily. Like obviously easy is a relative term when it comes to labor. And so if your baby is not well aligned to the pelvic level they're at, they may have a harder time moving through the pelvis. And this can cause a little bit of a stall, and then body's going to work hard to rotate. The other thing that can happen is your baby's head could be slightly tilted. Maybe their head is not in this good chin tucked position where they present much smaller. And so if your chin is to your chest, that very top crown of your head is what is going to be presenting. And the diameter or the circumference of that is much smaller than if your head is looking forward, or even if you're extended in your neck. Like that's going to be much bigger. Or if your head is tilted, that circumference is much bigger than that chin tucked. And so baby can present larger if their head is not in a really great position. And so with both of those things, the body's going to work hard to try to rotate, but it doesn't want to do too much and overwhelm the baby. And so it'll do like a burst of effort and then a bigger break, and then a burst of effort and then a bigger break. So you may have something called like a coupling of contractions or doubling, or like even double peaking contractions where you have like one contraction, it comes down, and then you have another contraction almost immediately, and then like 5 minutes break. And then you have like 2 contractions and like a big break, or 2 or 3 contractions like back to back and then a big break. So that's a clue to me that baby's position is a little bit off. Something else that I usually look for is I'll ask my doula clients of how does the peak of the contraction feel? Do you feel like it's one smooth peak where it comes up at peaks and then releases? Or do you feel like it comes up at peaks, releases, and then peaks again before it really lets go? So like double peaking contractions, or sometimes I'll refer to them as like bumpy contractions. This is usually a clue to me that baby's position might be a little bit off and your body is trying to help them move. Something else that I'll also really notice if babies are maybe a little bit in a funky position is you may feel contractions a little bit more like one-sided, like you feel a little bit more sensation to one hip versus the other. And you're also favoring like a lot of really tucky positions, like you're trying to create more space to help them have more room to rotate, or like things that I'm like looking for as signs that baby's position's a little bit off. So if I'm noticing those external signs that maybe baby's position is a little bit off, in addition to things don't seem like they're progressing, this is where more of that collaborative care can be really helpful. So like me as a doula, I'm limited on the tools that I have because I can't really do hands-on assessment. I'm not doing a cervical exam in somebody. I'm not palpating their belly to feel their baby's position. I'm not pulling an ultrasound out. So what are some ways, Roxanne, that we could integrate the medical team to help us understand what baby's position is, to help us figure out, okay, they're positioned like this, so these are the movements that we should try, or these are some tools that we can use to help support their position?
So there are tons of different things that you can use to assess the baby's position. If you want to stay like external, so you can palpate the belly to kind of feel where is baby facing, and then try to see, are they extended in their head, or are they tucked, or are they more of like a neutral position based off of like what their like head is doing in the pelvis. And this is all a palpation of the belly, but not every provider is super confident or super familiar with doing external belly palpations to assess like what the baby is actually doing within the pelvis. And sometimes babies, like their bodies could be a little bit bonier or like just feel differently than other babies because they're all individual like humans. So sometimes our assessment externally can also be wrong. Like it's not 100%, even though I would like to think I'm 100%. I'm not 100% at assessing a baby's position of what their head is doing as well as the rest of their body. So the other option, if it's available, is an ultrasound. Like you can do an ultrasound to see where is the baby facing and like is their head extended. But that's also limited depending on how well engaged the baby is, because they can't see what baby is doing like beyond the bones. So like if your baby is like super engaged into your pubic bone and like in your pelvis, like the ultrasound just cannot reach there.
I had a hard time at the end of my pregnancies when I was trying to get like a picture of my baby, and it's like, well, here's your pubic bone and a smushed a smushed baby.
Yeah.
So I can sympathize with if baby is well engaged. The ultrasound is a little
It's
bit more
just not
challenging.
effective at, seeing through bones. So, and we're not going to do an ultrasound. Like, we're not going to do an x-ray because like that's just not ethical and like not necessary in any sort of way. So the other option that I find is a little bit easier to kind of figure out, and then like if you have the ultrasound, use the ultrasound as like a confirmation, is using an internal assessment. So you do a vaginal exam, and at the top of babies' heads are like skull bones. They're all fused together. So like you can't feel like the suture lines of your skull as an adult. But a baby, those suture lines are not fully fused yet because they have to adjust based off of the space that's available within the pelvis to be able to fit. So we feel for those suture lines on the baby, as well as like the little soft spots, for lack of a better word. In the front of the head, the soft spot is a different shape than the back of the head. So the front is more of a diamond, where the back is more of a triangle. And we want to feel a triangle, ideally, because that means the baby, his chin is tucked, and that's what we're feeling is the back of the head where that triangle is, as well as all of the suture lines coming off of it. If we feel the triangle, but it's more to the right or to the left, and then that suture line is also more to the right or to the left, that's also telling us that baby is tucked, but is probably coming down what we would call asynclitic, or cattywampus is another one that someone calls it. But baby's head is pretty much just tilted. And this can be a good thing and a normal thing that some babies do to just kind of fit into the pelvis. But if they can't re-straighten their head back out once they're in the pelvis, then it could become an issue. If I feel the diamond, that means that your baby is not tucked, and either in a neutral position or more extended, depending on where within the vagina I feel that triangle. So where in the vagina I feel the diamond. So in those cases, that's when we would probably try to kind of adjust based off of what the baby is doing, where they're facing, what position we would want to try to encourage them to go into to create the most space so that baby can then reposition themselves, usually first starting with an inversion.
Let's take a break from this week's episode to hear about our podcast sponsor, Needed. Needed is a nutrition company that specializes in optimizing nourishment for the perinatal timeframe, and is a brand that Roxanne and I have personally utilized during our pregnancies and now into our postpartums. And you can use our code MamastePod to get 20% off your order. One of my favorite things about Needed is that you can a la carte based on what you're needing. And so they have their standard prenatal vitamin, which is much more than just a standard prenatal vitamin. They've done a lot of research on it, and they have actually done some clinical research trials to demonstrate the effectiveness and how amazing their prenatal vitamin is. But we don't want to put everything that you need in one vitamin, because some of these supplements may interact with one another and how well you could absorb it. And so Needed has some of these supplements separate based on what you may individually need. And one of the things that we kind of added on to our prenatal vitamin, but we took it a separate time, was Needed's iron.
A very common condition that can develop during pregnancy is anemia, and specifically iron deficiency anemia. And so not all of us need an iron supplement during pregnancy, but the few of us that do need an iron supplement during pregnancy because of our iron deficiency anemia, such as us with our low iron levels, it can be beneficial not to take it with your prenatal, because some of the nutrients within a prenatal vitamin can counteract the ability of your body to absorb the iron, which if we are taking iron, we would like it to actually do the things that it's needed to do. Some other iron supplements that I've taken have really led to some constipation and really upset tummies after taking it. But with Needed's, I didn't experience any of those symptoms. So it really kind of encouraged me to continue taking it. Whereas before I would stop taking it and just dealt with my anemia. And I also really like it because based off of your lab values, they tell you how many pills to take. So I was able to kind of discuss with my provider and be like, hey, I know I'm anemic. Can we do this level, our ferritin level, to tell me how much iron I actually need to supplement? Because of Needed's recommendation on their page, I was like, oh, I need this lab value to tell me. So I really love that Needed has that recommendation on their website.
During my last pregnancy, I was borderline anemic, and I started taking Needed's iron supplement, and within a few weeks, my levels had almost doubled, which I was really impressed by and was obviously very happy with as well. So if you want to check out Needed, you can check them out at thisisneeded.com and use our code MamastePod to get 20% off your first order. So there are kind of two areas that babies tend to have more stalls. Entering into the pelvis and then exiting the pelvis, which you might be like, Judah, that's the whole pelvis. Like it kind of is. But like those are kind of like the two main areas. Getting engaged, sometimes we can see a stall, and then exiting and finishing the rotation, we can sometimes see a stall. And there's a little bit different solutions for each of them. And they're kind of relating both to both baby's position and the physical structure that they're passing through. And so I find that the passage and the passenger stall are really commingled with one another. The first thing that we're going to do in both situations, if your baby's having a hard time engaging, or you have a late labor stall, you're like 8 centimeters, or you've been pushing for forever and they're just not rotating, is we're going to try to invert. The reason being is this sometimes brings baby to a space where they have a little bit more wiggle room, or it's just kind of like gives them a little bit of anti-gravity, so they can sometimes just adjust their head position. And sometimes that's all you need. Sometimes just like a little puppy pose for like one contraction, and you feel a shift. And then your baby's falling out of your body. No promises. But I have had that happen where all we really needed was for baby to adjust their head position. They tucked and then they just flew through the pelvis. And that's a really common thing that can occur. So the first thing we're going to try is some sort of inversion where your hips are higher than your head. You can do it on the bed. You can be on 2 different levels where you have your arms on a lower surface than your knees. So that would be like a forward leaning inversion, a little bit more intense of an inversion. You could do more of like a puppy pose where your knees and arms are on the same level. So it's essentially a much more relaxed inversion, but sometimes it's really all you need. If you have an epidural, you can tilt the bed. You can Trendelenburg it. Usually you're going to need your nurse and provider support for that one. I would not recommend partners trying to like tilt the bed themselves. So you can tilt the bed to sometimes help baby adjust their head position. So those are kind of like the main inversion options that we can use to see if that's enough. Like, does that cause things to shift for you? And that's how you're going to know that your stall is resolved. Things change. Where like things are different now. The pressure feels different. I feel more pressure. My contractions are closer together. They feel stronger. There's just going to be some sort of like shift that happens. If you do your inversions, you're like, kind of feels the same. I don't know if that was it. I think I need more. If your baby's having a hard time entering into the pelvis, we want to help them rotate so they can then align to the inlet and enter into it. And we're going to do this with more open hip position. So we can do like with the belly down. So like a tabletop position where you have one leg on a peanut ball and a fire hydrant. That's going to help rotate baby a little bit more towards the front. If you cannot get into a tabletop position, you can also do like exaggerated side lying where your leg is up on the peanut ball. And for those of you listening to the audio only, know that in the show notes, we're going to link a video where we talk about addressing labor stalls, where we're showing you all these different motions. And in the podcast video, we'll have some overlay images of this is what that position looks like, because sometimes it's a little confusing. So after we do like a fire hydrant or an open hip position, so essentially like knee is away from the belly and belly is a little bit more towards the floor, probably hold that for like 20 to 30 minutes. We're then going to move to a little bit more of an upright position. So ideally what has happened is we did the inversion, baby adjusted their head position. We then did an upper mid-pelvis opener with our open hip position, belly to the floor. So they ideally rotated to align to the inlet. And then we're going to kind of shift upwards so baby can drop into the pelvis. And you could either do like an elevated lunge with an open hip position. You could do like a deep squat. If you're in the bed, you can do like a throne position. So there's so many different movement options that you could do to help baby just kind of drop into the pelvis. And then hopefully we feel a shift. Something has changed that can happen. Other things that we can kind of add in for releases. So let's say the passage is the issue. Like there's movement restriction along the way. We can think about releasing the lat musculature. We can think about releasing the hip flexors because sometimes those two muscles are a little bit tight and is pulling the pelvis into one specific position, making it hard to have good pelvic and rib and spine mobility. So if we release those two muscles, sometimes that can help things really shift to allow baby to enter into the pelvis. We can also do like some belly sifting or massaging like of the belly to release tension in the uterine ligaments. That can sometimes help with babies dropping down into the pelvis. You can also do jiggling, which I think feels really good. It is so nice, where you literally are just shaking your booty with the hands.
jiggling.
So you're not like
Shaking
twerking.
seems
Somebody is placing
excessive.
their hands against your butt and like shaking. And that is like really relaxing for it. I don't know why. I mean, I don't know why. It's stimulating the fascial layers, which releases endorphins, but it feels really good. It looks super silly, but it feels really good. So we can try some release techniques, such as releasing the lats and the hip flexors to improve pelvic mobility. We can release muscularly or in like the tension by doing some belly sifting, belly massage, jiggling of the legs or the glutes. And hopefully that has all helped your baby really drop into the pelvis. If baby's still having a hard time entering into the pelvis, we can do the quote unquote magic moves. And we have a whole podcast episode where we talk about the magic moves of labor. And we have a YouTube video where we break down this position, which is called Walters. So Walters is where your legs are essentially hanging off the end of the bed. And that position really brings you into a little bit more of an arched position that is changing the pubic bone angle and sometimes can really help babies drop into the pelvis. And so this is one of those moves where if it's going to work, it's going to like work really well. And so this will be like kind of like a last resort type of thing. It's really uncomfortable to be in. I would not say like if your baby's having a hard time engaging, do it right away because it's like not comfortable to be in. But we have an entire podcast episode where we talk about these magic moves and the nuances of them, and a YouTube video where we break down Walters as well if you are curious about it. The next area that babies sometimes have issues moving through is the pelvic outlet or the lower mid pelvis. So babies having a hard time finishing that rotation to get underneath the pubic bone. This typically happens at like 8 centimeters, or if you've been pushing, you're pushing for like a really long time and it's like, and it's just like peekabooing with you, which is the worst. And so with this late labor stall, we're trying to create more space in the lower mid pelvis to help baby rotate underneath the pubic bone. So if it's an engagement issue, we're trying to create space in the upper mid pelvis to help baby rotate to enter. If it's a late labor stall, we're trying to create more space for baby to finish that rotation to extend underneath the pubic bone. And so we can approach it with the same way where we start with those inversions to see if maybe baby's head position is just a little bit off and that's what's causing the labor stall. And sometimes that's all we need. Usually I find with like the late labor stalls, if the inversion is going to work, this is where it's more likely going to be because sometimes it's just baby's a little asynclitic. They're a little tilted. And then once we invert, they tuck and then they just like fly out of your body. After we invert, we can then either do some releases, so releasing in the pelvic floor musculature, either with jiggling, again, of the booty, just
the booty jiggles
the
just
booty
throughout all
jiggles
of labor
are
honestly.
usually a
Just
big
never stop
thing.
shaking the butt.
Any sort of hip shifted exercise is helping to stretch the pelvic floor musculature. You can try sitting on the toilet and see if that helps to relax your pelvic floor. And you can also do like a sacrotuberous massage where it's like in between your tailbone and your sits bone. There's
next
like
to your butthole.
This little pocket of ligaments that you can massage, and that can sometimes help with sacral mobility. So those would be like a few different release techniques that you can try. After you do like some release techniques, you've tried the inversion, you've done the releases to help try to create a little bit more space, we can then move into some positions that help to really open up that lower mid pelvis, which are going to be our hip shifts. If you're unmedicated, you can really do a hip shift anywhere. You can do it standing, you can do it in the bed, you can do it on all fours. It really just depends on like wherever you feel most comfortable. But with a hip shift, what we're trying to do is rotate the pelvis on the femur so that we feel a little bit more of a stretch in like the hip pocket area. So if you're wearing some jeans and you put your hands in those jeans, you're feeling a stretch kind of where one of your hands is a little bit more. And so this is stretching more of the back half of your pelvic floor, which can help to improve how well your sacrum can move and how well you can create space underneath that pubic bone. So with the hip shift, you can do it standing where you're really just shifting your weight from leg to leg, bring the belly a little bit more towards the thigh. You can be in a tabletop position. So this is a great option if you're in the bed or even if you have an epidural and you can get into a tabletop position where you essentially just shift your weight over towards one knee, bringing that belly more towards that thigh. You can place a pillow underneath the knee too. So sometimes I'll just fold a pillow in half and place it underneath the knee just to have a little bit of elevation on that side. And that can help you get into a little bit more of a hip shift. Your partner can do a single knee hip shift for you. And then you can also do something called a side lying release, which is not a hip shift, but it is like a good relaxation exercise as well. That does bring the bottom of the pelvis a little bit more open. However, it is not comfortable to be in towards the end of labor when you're having a late labor stall. So it is another one of those magic moves that I would say is a late or a last resort type of thing. It wouldn't be like my first
Feels
line
very
of
nice
action.
during pregnancy.
It does not
Does
feel
not
great
feel
during
great
labor.
while having a contraction.
But similarly, we have a video where we break down the side lying release in addition to those hip shifted exercises that we were talking about, which would be kind of like our first line of offense, defense, I don't know, whatever the terms would be. So we break down not only the side lying release and kind of what's happening with it, but also these prerequisite exercises that I would try first to help create more space in the bottom part of the pelvis. So if your baby's having a hard time finishing that rotation, you're near the end of labor, it's a late labor stall, typically we're going to start with an inversion to see if maybe baby's head's just a little bit funky and that's what's making it hard. If that's going to work, it's going to work really quickly and you're probably going to start pushing very, very shortly after that. We can then think about releasing tension in areas, so jiggling, pelvic floor relaxation exercises, massages of like the sacrum. We can then move into some movements that create more space in the bottom part of the pelvis and the lower mid-pelvis with hip-shifted exercises, either standing, all four, a partner-supported one. And then our last line of offense, we'll figure out what the word would be. Defense? Last line of, or is it defense? I feel like it'd be offense because we're doing something.
But we're doing something in reaction to something that they're doing.
Anyways, whichever it is, my last resort would be like a sideline release would be what I would use to help really see if we can shift things around. But yeah, hopefully with all of that, things shift and then your baby is just like, all right, fine, I'll come out if you insist. So the two areas that I commonly see stalls related to baby's position or to the passage is going to be they're having trouble entering into the pelvis, where we're going to think about invert, release tension to make it easier for the baby to move around, and then we're going to create space in the upper mid-pelvis. So open hip positions. If baby's having a hard time finishing that rotation underneath the pubic bone, we have a late labor stall or pushing for a while, we're going to think invert because maybe their head's a little bit off. We're going to think about releasing tension, again, mostly in the pelvic floor type area. So if it's engagement issue, the releasing is typically pelvis and up. We're kind of releasing up here to improve mobility to help baby drop down. If the issue is the lower part of the pelvis, we're releasing more of like the pelvic floor, sacral area to help release tension. And then we're going to think about closed hip positions and creating space in the lower mid-pelvis with like hip shifted movements. So those are like our tips for that. We have like a whole PDF guide in our childbirth education course that includes this stuff as well. So if you're like, oh my God, that was a lot to remember, there is a PDF guide inside our childbirth education course that you can just download and print out if you are in our courses. So you do have to join the course to receive the PDF. But again, I love showing at birth where people have the PDF printed out and they're just referring to it because it also
I think one person
includes-
had like a binder of literally all of them. He would just
because
like,
it has what labor positions to do if your baby's here, what to do if you're having an issue here. And so it's really nice because they already have all of those tools available for them. And you can too by joining our online childbirth education course. But we'll link in the show notes below all our videos that we break down some of these exercises as well so that you can be more familiar with them. And then our prenatal fitness programs, this is where a lot of the stuff that we do in our prenatal fitness programs is helping you to ideally avoid labor stalls because we are helping one to support baby's position with our exercises so that there's easier for them to change positions. We're releasing tension. We have balance. We're supporting their head position with different movements, in addition to being able to create space within the pelvis. And so I never want to blame anybody for like the stalls or issues that happen during their labors. But if you are more familiar with movement, it's going to be easier to create the space and it's going to be easier to do the things to help adjust issues. And so if I had to pick one movement to help you prepare for birth, I would encourage you to be really familiar with hip shifting, to learn how to find a closed hip position so that we can create space in the bottom part of the pelvis, because I tend to see more issues here than anywhere else. And our prenatal fitness programs include a lot of exercises to help you create space in all the different parts of your pelvis. So Roxanne, what is your experience as a medical provider with managing labor stalls. Because commonly, if somebody's labor is not progressing, so they don't have contractions or they're spacing out, they're irregular, their temperament is kind of the same and their cervix is doing nothing, do we just give them Pitocin? Because it sounds like all of the stuff that I was talking about, how we could help babies position, how we create more space, did not involve making their contractions stronger.
Yes. So usually in a hospital, and like prior to me like understanding the like full spectrum of labor, usually the answer was like, oh, they've been 4 for the past 8 hours. We need to give them Pitocin. And sometimes, very rarely, but sometimes it is truly like could be beneficial. Like if their contractions truly are just not strong enough and baby, but it is in an optimal position for their body, Pitocin could be helpful in some situations. But if the reason for your labor stall is your baby's position is not optimal for your body, or like there is some like tension within the path that baby is kind of navigating through, giving Pitocin is not going to change likely the baby's position. If baby is in an unoptimal position for your body and you're having those contractions where you're having 1 or 2, like 2 or 3 in a row with a long break, 2 or 3 in a row. So we're never going to pit through an abnormal contraction pattern. So if you're having these like back-to-back contractions with a long break, that is their sign to us that we need to help this baby reposition, not just give them not give them more Pitocin to make these contractions just stronger. That potentially is just jamming this baby that is, like you said, a square hole with a square peg that is like in a diamond shaped. Like, yeah, I'm just going to continue to jam this diamond into this hole and eventually it's going to fit. But that's not what's actually going to happen.
I mean, my 2-year-old that does it eventually learns, oh, if I turn it,
yeah. But like sometimes if you just keep jamming it, like it could like hurt the little square cube. Like that's basically what's happening, which means like this is going to cause distress for these babies. Or we're just going to like jam this baby into the pelvis in this malposition to a space that they don't have as much room to reposition themselves, which then could lead to a C-section because that baby can't reposition themselves or come out of the pelvis. So Pitocin should never be our first line if someone is having a stall. We need to figure out what is causing the stall. And if it is truly baby's position, we need to fix the position to be more optimal, like repositioning them, or if there's like tension within the pelvic floor, help them address like by releasing those tensions. But that's not always taught to people in hospital settings or in residencies like, hey, there's 3 reasons that someone can have a labor stall, these, this, and this. These are the solutions that we can do before going to Pitocin. Sometimes, yes, like the baby could be in a funky position, then we fix the position, but that still doesn't lead to stronger contractions. And then, yeah, maybe in that point, Pitocin could be helpful if in whatever instance that is. But if we don't fix the position or the reason for the stall before adding in interventions, then this is just increasing and leading to that cascade of interventions that everyone talks about in hospital settings. So if anyone ever, like when we are doing our vaginal exams, if we check one and they're the same that they were 4 hours ago, this is when the problem solving begins of like, hey, is this just their normal pattern? Because everyone kind of progresses normally throughout their labor. Or like, what is this baby doing? Like, let me see what this baby's doing within the pelvis, because they get a say in how they come out as well. They got to shimmy through. That takes a lot of effort for them. And then what is like the pelvis feeling like? Like, what is going on with their pelvic floor and their body? Like, have they been in this one position for 4 hours and have not moved? Well, let's move, maybe. Let's give the motion. Give the body some lotion with some motion so this baby can come out. And sometimes literally that's all we need to do is literally just move them from the position that they've been laying in for 4 hours, especially with an epidural. We want to still be repositioning them. But if it's been 4 hours and you have not, oh, it's shocking how if you just position them to the other side, that labor progresses.
So this feels a little bit like the chicken and the egg kind of conversation for me, where For me, before my first labor, I was very anxious about Pitocin. Like, it was something that was really scary for me. And so I think that there are a lot of people who hold very similar fears about Pitocin. Like, there's a lot of negative kind of commentary about Pitocin. Like, you should never get it. But on the other hand, it also is overused.
Yeah.
And so it makes sense that there is this fear of Pitocin when it's really overused and being used in scenarios where, like, in theory, like, you would think, like, well, that makes sense, but, like, in reality, it doesn't. And so Pitocin is a tool that's available to us. I think understanding that there are a lot of people who are fearful of it for good reason, too, because it is overused, is important to maybe encourage providers and medical teams to consider, well, what other options do we have before Pitocin? Because this could help my patient feel more confident and comfortable.
Yeah.
So that they know we tried other stuff before we made it to Pitocin. Or if I'm noticing the signs are more related to the strength of the contractions, then Pitocin can maybe be an option. We're going to do a whole mini episode on power stalls, which are a little bit different than the passenger and passage stalls. So there is the fear with Pitocin that I think is very prevalent. I think that there's good reason that people are scared of it. It is overused, but it is a tool that's not bad or evil. Like, there are good times to use it. And so not jumping to it right away is probably going to help your patients to be more comfortable and confident in your care, that you're just not doing stuff because it's easy. Because giving Pitocin
super easy
is easy compared to let's get into these positions. Because, like, my like the story that I'm painting in my head is the nurse comes in, she hangs the bag, she does some buttons on the thing, and she's like, okay, well, I'm going to watch you on the monitor, bye, and then leaves. While if, like, they had to help with positions, well, they're not going to be like, okay, well, bye. Like, they're going to stand there and help you with the position, make sure that it feels good for you before
it's more labor
they can leave. So there's more effort on their
repositioning
part,
is more labor intensive,
which I could see being hard if you're understaffed and you don't have that many people working on labor and delivery. And so what I would recommend to people that are listening, because you might be like, oh my God, well, now it's my responsibility to know all this stuff, is one, like, yes, some education is really helpful so that you can, one, make sure that you're choosing a team to support your birth, like a medical team to support your birth that you feel is going to help to really guide you during your experience. And maybe that's not the closest provider to you. Maybe it's one that's a little bit further away. It doesn't have to be the OB that you've been seeing since you were 16 for your annual pap smears. I don't know
which
when
you shouldn't be getting pap
I don't know
smears
when
at
you get
16.
pap smears.
21, guys.
21. Since you've been seeing
every
your
3
whole
to 5
life
years if
for,
they're normal.
So it doesn't have to be just like your standard gynecologist that you've been seeing your whole life, or your family medicine doctor, or whoever. Like, maybe it's a provider that's a little bit further away that you feel more comfortable with, that you think that you know is going to explore stuff with you a little bit more. So first thing is choosing a medical team to support you that you feel confident is going to actually, like, support you through a variety of different experiences.
And look at the full picture, not just medical interventions.
So in addition to choosing your medical team, you can also choose non-medical support people to support your birth as well. So one, your partner, and you and your partner educating yourselves on your options and being informed on the interventions and the non-medical interventions that you have available to you. So understanding different laboring positions, different movements and stuff that you can try. Know what a peanut ball is. Know how to use a birth ball. Know comfort measures. All of that stuff can be really beneficial to helping you be able to navigate your labor experience with more confidence as well. Like, you don't have to do it all yourself, but being informed on what options are available is going to help you to facilitate conversation so that you can receive the care that you're wanting as well. And so in addition to the medical team, your partner, you can also have other non-medical support persons, such as a birth doula, which are typically very familiar with labor, and they also tend to have a good relationship with you, ideally, and they're going to be with you the whole time. So, like, your labor nurse will kind of come in and out. Your provider will kind of pop in once, and then you'll probably see him again when your baby is crowning.
If you're at a hospital.
So in addition to your medical provider, your partner, other non-medical support people that you can have support your labor is going to be like a doula, or even like a friend or family member that is really well versed in labor. Maybe they've had a bunch of kids, but depending on how many kids they have, they may not
have time for you.
They might not have time to support your birth. So, like, within reason. But having this non-medical support person that is going to provide continuous labor support can be incredibly beneficial, especially if they are familiar with laboring positions and movements to kind of address these issues during birth. So for me as a doula, I am much more well-versed in movement than Roxanne is. But Roxanne is more well-versed in like medical interventions and things like that. And so the combination of our powers combined provides tons of amazing labor support. And so my expertise is going to be with movement because I don't have other things in my toolbox. My toolbox is full of a lot of movement and hip squeezes. Roxanne's toolbox is a little bit bigger with some other things within it. And so combining efforts together is going to provide better labor support. But the big thing with a doula is they provide continuous labor support. Your labor nurse will probably be popping in and out because they've got other things that they are focusing on, maybe like another patient sometimes. But typically, your labor nurse is not going to be in the room with you your entire labor, especially if their shift is over. They're going to go home. Unless your baby is about to fall out, then sometimes they stay. But typically, they're like, bye, my shift is over. Here's your new friend.
You have kids too.
But they're going to be kind of popping in and out. While a doula is going to be with you, ideally, the whole time. Like from whenever you call them until your baby's born, they're with you like right in the room, which is one of the big reasons why like I have been able to really identify like these little subtle cues of labor progress and what is going on because I'm literally just watching somebody labor for hours. Roxanne's not sitting in the room with you watching you labor for hours, but Gina is.
At the birth center, I do though.
Yeah, so different hospital settings or different birth location settings, it will be slightly different, but typically in a hospital setting, a doula is going to be with you the whole time while other support people may be coming in and out, especially the medical support team. And so having other people there who are really familiar with labor and are familiar with the subtle cues of labor shifting or maybe not shifting in the way that it should can be really beneficial as well. So be picky on who you choose to support your birth. You and your partner educate yourself on your options and be informed on what is available to you at your birth location. And then consider having additional support people there for you. So like I had Roxanne at my labor, I had my mom, I had my husband, and I had Brittany, our birth photographer / doula that was there. And everyone was like, would see moments where I needed a little bit more and would provide that additional support for me. And it helped me feel so much more confident during my own labor. And I had some stalls during my own birth. Roxanne has had some stalls. And so just because you have a stall doesn't mean that there's like something inherently wrong with your labor. Sometimes it's just like a little movement shift that we need to do.
Sometimes your babies are 8.5 pounds.
Yeah, it's just, you never know. But thank you so much for listening to this podcast episode. Hopefully it gave you some tools on what to do if your labor is stalling, which again is not necessarily bad, but we may want to address it with different movement techniques to help either adjust baby's position or to create a little bit more space within the pelvis. Again, check out the show notes. There's going to be tons of resources in there for different movement techniques. Check out our online childbirth education course where we break this down with video demonstrations in so much more depth with a PDF guide where you can just print out and then just have it available for you in your labor. So you can just
Laminate
reference,
it.
you can laminate it, you can take notes. It's a
I'm
pretty
in my
nice little
laminating
guide
era.
that we're very proud of. And then check out our online prenatal fitness programs because we include a lot of movements within it to help support your pregnancy so that you're comfortable during it. And also to help prepare you for birth by ensuring that you know how to do movements to create space in the different parts of your pelvis, to release tension within your pelvic floor, and to support your baby's position. So check out our online courses. You can bundle them together to save 15% off, and then you can add on another 10% off with code STORY10. And this podcast is sponsored by Needed. Needed is a nutrition company that specializes in optimizing nourishment for the perinatal time frame, and you can use our code MamastePod to get 20% off your order.